Hi, everyone. My name is Annie Rubino, and I want to thank the Voice Foundation for this opportunity to participate in this online conference. And I hope everyone is doing well. So let me bring up my presentation. So today my presentation is about identity and voice therapy outcomes. I'm going to present a model for adherence, habilitation, and rehabilitation of voice. As I said, my name is Annie Rubino. I'm a PhD student at the University of Delaware, and my academic advisors are Dr. Verdolini Abbott and Dr. Dietrich. So just a little introduction here. So as we know, voice disorders, adherence, rehab, and habilitation are multifactorial. We see that on certain caseloads, the non-adherence numbers are actually quite high to voice therapy. So in studying adherence to voice therapy recommendations, self-efficacy has been isolated as a variable that affects adherence and rehabilitation. However, more variables have been found to be non-significant. So for example, gender, age, quality of life, all these things have been found to be non-significant in regards to adherence and rehabilitation in voice therapy. So of course, the search is on for more variables. So I would like to suggest that identity is a factor or variable that might impact adherence, habilitation, and rehabilitation. However, to my knowledge, has not yet been studied. A little definition here, I'm using the definition from dramaturgical theory of identity as the sum of behaviors that a person presents for a certain time, place, and audience. So of course, this would include vocal behaviors as part of the identity. I'm an MFA trained actor, so because of that background, I take a lot of inspiration from actors as they change their vocal behaviors according to the role or identity that they are portraying. So for example, we see Florence Pugh as Amy in Little Women. Her identity is reserved, practical, she's a wife and mother, so her vocal behavior follows that. So she's using a limited volume range, a limited pitch range. She's using, within normal limits quality, a little bit of fry comes in as well. Big contrast with Paige, as Paige in Fighting With My Family. Even between the two photos, there's a huge change. As Paige, she is dominant, she's brave, she's a wrestler. So her vocal behavior follows this identity. So wide volume range, wide pitch range, pressed or a fry vocal quality. So now I'm going to connect vocal behavior to identity to voice therapy. So Brown, Kaka, and Yuan, in a recent study, they discovered that there were cortical changes in identity with changes in vocal behavior. So they found deactivation, specifically in the medial prefrontal cortex, which is commonly associated with self-processing, during two acting conditions. The first was participants answering questions as Romeo or Juliet, and the second is participants answering questions as themselves, but using a British accent. So, research has shown that actors change their vocal behavior to portray different characters. So the conclusion that I'm coming to here is that alteration of vocal behavior prompts changes in identity at a cortical level. And this is the conclusion that Brown et al. Came to as well. So how does this tie into voice therapy? Well, in voice therapy, as clinicians, we are encouraging changes in vocal behavior. So for example, from pressed phonation to an easy manner phonation. So going back to identity theory, in self-determination theory, we see that one constructs one's identity in order to achieve certain salient goals to them. So let's say that the salient goal is to be seen as someone who is brave, right? So the person would then use vocal behavior that fit that brave quality. And then going down to another theory in identity is the self-verification theory, that individuals are motivated to preserve their self-views. So the person who sees himself as brave is motivated to preserve this view of themselves. Therefore, they're motivated to continue that vocal behavior that is associated with the brave identity. So altogether, this suggests that changes in vocal behavior as encouraged in voice therapy disrupt identity at the cortical level, and that this disruption hampers the patient's ability to conceive of herself in the same way and to achieve important goals in her life. So therefore, this suggests that identity and change in identity is a mechanism for non-adherence, lack of progress during treatment, and recurrence of the voice disorder. So whenever I talk about these ideas, I get the question of, well, what about personality? Aren't you talking about personality? Well, what's the difference between personality and identity? So I'm going to talk about that now. So just a general definition of personality is that it's a psychological system composed of a group of parts that interact and develop and that impact a person's behavioral expression. So the parts are personality traits. And personality traits are defined as the relatively enduring patterns of thoughts, feelings, and behaviors that distinguish individuals from one another. Also, we see that personality is genetically determined. So just a side-by-side comparison here. So personality has a genetic basis. Identity is constructed to reach salient goals. Personality is relatively constant across the lifespan and situations, whereas identity is subject to change across the lifespan and relatively situational. So it's affected by the time, audience, and the place. Personality has a limited number of parts according to the taxonomy that you might ascribe to, so 3 versus 5 parts, whereas identity has multiple permutations according to the situation. So personality has been studied in voice. We know about the trait theory, which has tied functional dysphonia to low extroversion and high neuroticism, and vocal fold nodules to high extroversion and low constraint. However, with identity, it's primarily been studied in voice within the trans population, but these ideas have not been generalized to cisgender people. So because, going back to personality, because we know about the trait theory, personality is currently considered during voice therapy per etiology and treatment. However, identity is not systematically considered during voice therapy. However, my argument is that it could be a valuable tool to explain variance in adherence, habilitation, and rehabilitation in voice therapy and potentially in other fields as well. So this leads me to some questions. So why don't non-actors who have behavioral voice disorders change their vocal behavior, which I'm defining as rhetoric actions that produce different pitches, volumes, and qualities? So why don't they change these as readily as actors? So this is a question because we do see that non-actors do change their voices regularly. So this is through proto-acting. So non-actors use different voices while they're reading a book to a child. So Papa Bear says this and Mama Bear says this. Or they might change their voices while they're mocking someone. So, you know, and then my mechanic said blah, 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 blah. So we see that voice disorders are disruptive across many domains of a person's life. So including occupations, social interactions, actions, and even their mental health. So given this information, why don't some people adhere to voice therapy programs? Of course, knowing that adherence is multifactorial. And keeping that in mind, excuse me. Additionally, given this information, why do some people demonstrate better outcomes in habilitation or rehabilitation of voice? Is it because learning a new vocal behavior, which of course is intended to replace the old vocal behavior, is threatening to some people's identities? So the vocal behavior that they've constructed in order to reach their salient goals, for example, as being seen as a brave person. So does the loss of ability to conquer salient goals relate to non-adherence and or incomplete rehabilitation, habilitation? So here's my model. And this is my hypothesis regarding the influence of identity on voice therapy, adherence, habilitation, and rehabilitation. So at the beginning, you have a baseline identity, which is defined by a baseline vocal behavior. For example, oppressed phonation. So this vocal behavior, continued use of it, results in a behavioral voice disorder, for example, vocal fold nodules. So then the patient goes to voice therapy and they're asked to change their vocal behavior from oppressed phonation to an easy manner of phonation. So because of this change in vocal behavior, the individual experiences a change in identity. So whereas before they had conceived of themselves as boisterous, now they conceive of themselves as meek. So if they accept this new vocal behavior and they accept this change in identity, then we're going to see adherence, habilitation, and rehabilitation. If they reject it, then we're going to see non-adherence. We're going to see them retain their baseline vocal behavior and their baseline identity. And then, of course, they're going to retain that behavioral voice disorder despite the multiple impacts in their lives. So, of course, keeping in mind this note here that baseline identity and the changed identities are perceived by the patient when they go to try to achieve those salient goals, whether they succeed or don't succeed. That's how they will determine whether their identity has changed or not. So, there's also the cortical shift as well, but people are going to measure this attainment of goals when interacting with other people, and that's how they're going to perceive that the identity has changed somewhat. So the application here is, I'm thinking that if we systematically consider identity in our patients, that we can tailor our treatment to our individual's baseline identity or an identity that they want to step into as a result of voice therapy. So you have a person who has an identity as a commanding person. So rather than asking that person to speak at a lower volume, we're going to teach them how to use their voices in that commanding manner, but in a healthy way. And, kind of the flip side of that is we have a person who habitually uses a quiet volume, and that person wants to learn how to use a louder volume. So we're going to target the volume issue towards that person's target identity. So overall, I want people to consider the personal and social impacts of the changing voice in regards to identity. So some additional thoughts on identity and voice. So what does the patient get by voicing this way? So for example, the commanding person, by voicing this way, they get attention. And that's an important goal for them. So if you ask them to voice in a way where they're not going to be getting that attention, then they might accept that change, or they might not accept that change and become non-adherent and just retain their voice disorder because that attention is important to them. And then that feeds into my second question here, which is what is the patient giving up by changing her voice? So my overall goal here is to improve adherence in voice therapy as well as voice therapy outcomes and maintenance. So thank you very much for watching my presentation. Here are my references. And thank you very much.